There are ECG conditions that will shout at you, and there are others that will just whisper. And the case that we're going to talk about today is one of those. If you miss the whisper, your patient may die. And trust me, you don't want that. Let's have a discussion about this case.
To go now. So thanks everyone for joining today. My name is Hesham Ibrahim. I'm one of the emergency medicine consultants in the United Kingdom. And it's my pleasure to be with you for the next hour talking about something that I love talking about, which is ECG interpretation. So I'm not going to waste any of your time. Let's just jump straight into a case so I can gain your attention. So you're about to see a patient who's 63-year-old presented to me when I was an ED registrar in Poole Hospital many years ago with a cardiac sounding chest pain that's been there 12 hours before presentation, and on arrival to Poole Hospital, he was pain-free. So there is an important thing to clarify here regarding Poole Hospital. So Poole is a lovely city by the south coast of England. It's a nice place to be in. And what you need to know about this emergency department is this hospital doesn't provide an in-house cardiac support. So if you need a cardiologist, in Poole Hospital, there is no one. So you'll need to ring a nearby hospital, and which is Bournemouth Hospital, to transfer the patient there. So if you have a patient who's got a STEMI, for example, and you need the cath lab activation, then you need to go straight to ring Bournemouth Hospital and transfer the patient to Bournemouth. If you've got something that doesn't require an immediate cardiology input, you can admit in Poole Hospital under the medical team, and then they can liaise with cardiology later. So this is just to give you a bit of a background about what resources are available for you dealing with this patient. Back to our patient. So he came into the hospital. He didn't want to come to the hospital, to be honest. He was kind of forced by his wife to come and get himself checked. 12 hours before coming to us, he's had some cardiac sounding chest pain. The pain lasted for some number of minutes and then improved, and he was pain-free on arrival. So coming to us, he was pain-free. He's had serial ECGs that didn't show any dynamic changes, and his troponin with us was negative, and he's had no old ECGs to compare with, and his ECG, when we saw the patient, was this. So I'm going to give you a few seconds to look at this and allow you a chance to think about what could be going on here before I ask you the question of what would you like to do next? So I'd like you to scan this QR code on the screen now. It will open a page on your mobile phone with this question. You can see the ECG on your mobile phone, and you can make it bigger by turning your mobile phone to the side. And I want you to pick one of the three answers. This is all what I could think of that you might be thinking of. Either you'll be thinking that you're going to admit this patient under the medical team in Poole Hospital, or you're going to transfer this patient to the cardiology team in Bournemouth Hospital, or you're going to discharge this patient, considering that the patient is pain-free with a negative troponin, to come back to the chest pain outpatient clinic. Please pick one out of the three. Okay, let's see what you guys think. Okay, so 78% so far are going with, we're going to refer to cardiology in Bournemouth Hospital. And we've got 22% with, we're going to admit in Poole Hospital under the medical team, and 0% send home for chest pain clinic. Excellent. So what I usually do when I reach this part of the talk is I advise the audience to contribute. So can I have a volunteer from one of the 21% who said admit to Poole Hospital under the medical team to tell me why do you want to do that? Any volunteers from the 21%?
There is T-wave inversion on V1 to V4, which can lead to indicate acute ischemia.
Okay. And so you've chosen to admit under the medical team in Poole Hospital. Is that correct?
Yes.
Great. So, fine. Do you want to refer the patient to me and tell me why do you want to admit this patient? I am the medical registrar in the hospital, so you can try to refer and let's discuss the reasons for the admission.
If this T-wave inversion is new changes, I would, and if the patient presents with like acute chest pain, I would like to refer him to have a troponin done and to rule out acute coronary syndrome.
But you said to me that you've already done troponin in the emergency department and it was negative. So why do you want to admit for another troponin?
No, I missed this part, sorry. I didn't know about it.
So now knowing that the troponin is negative, do you still want to admit the patient under the medical team?
No.
Okay. Any other volunteers who wanted to admit under the medical team in Port Hospital? Anybody else? Okay. So shall we go to those who said cardiology? Any volunteers to tell me why you want to refer to cardiology? That's the majority. That's almost 80% of you. So I can see that some of you are...
Can
Yes.
I speak?
Of course.
Because troponin could take time to become positive, and there's a T inversion in there. But we need to find out more about this patient. If the patient didn't have T inversion before, that's a new T inversion. That must be cardiac reason. We need to search for the cardiac reason for that. Is that right?
So you want to refer to the cardiology team in a different hospital and admit and transfer the patient to a different hospital because you're saying that there is a T-wave inversion in the ECG that could be new and the troponin can take time to turn positive. So that's why you want to refer to cardiology. Is that what you're saying?
That's what I'm saying, yes.
Okay. So the thing is, this troponin was done 12 hours post-chest pain. So it's highly unlikely that it will be negative then turn positive if the ischemic event was 12 hours ago. So the chances are this troponin will stay the same. So that's regarding the troponin part. Regarding the T-wave inversion part, if you speak to cardiology, what they'll say to you is, well, if the patient is pain-free and there is no ST elevation that requires any immediate cardiology intervention, and you have any concerns about the ECG, these concerns can be new, can be old, the changes we don't know, then in that case, this patient wouldn't trigger an immediate transfer to Bournemouth Hospital. You can admit under the medical team, and then they can do whatever they want, and if they find something cardiological, they can call us back. This is usually the response that you will get from cardiology if you refer them the patient this way. So,
but in the trust I'm working, they will accept that patient. That's a big, if we don't have any background of the patient, if there's a T inversion wasn't there before, that could be the new finding. This patient needs to have angiogram and everything to find out what's going on.
So are you saying to me that in your trust, you send every single patient with presumed new T-wave changes to the cath lab, even without chest pain and a negative troponin?
Not every patient, but most of if the patient is reasonable with the T inversion and with the ECG I can see in front of me, I think I fax the ECG and I'm pretty sure they would accept to see the patient.
Okay, this is very interesting. Sorry, do you practice in UK?
Yes.
Okay, excellent. I'll be honest with you, I'll be really surprised, especially if the cardiology department is in a different hospital, that the cardiologist would accept a transfer of a patient who's pain-free, negative troponin, just because the ECG is showing T-wave inversion, because there is no proof that these are new changes, and there is no proof that these T-wave inversions are because of an ischemic event. Pulmonary embolism can cause this as well. So there are other causes of T-wave inversion that can cause something like this. And this can be the challenge when you talk to cardiology, and they'll challenge you back and say, you need to prove that this is an acute ischemia first before you refer to us. So I'm not saying that you're wrong doing what you're doing, but what I'm saying is if you look at the chat, it looks like few people mentioned the word Wellens in the discussion. So without mentioning the word Wellens, I am not really sure if cardiology will accept that referral. So let's talk about Wellens syndrome, because this is an important condition that we'll need to talk about today. So Wellens syndrome is a relatively new medical condition. It's been first reported in 1982 by Dr. Hein Wellens, who is a Dutch cardiologist, and it described specific T-wave changes in the midprecordial leads. So that's leads from V2 to V5 without ST changes, without significant ST changes to be accurate. So specific T-wave changes in the midprecordial leads, that is Wellens syndrome, and it's highly specific for severe stenosis in the proximal part of the left anterior descending coronary artery. This is the first paper that was published talking about Wellens syndrome in 1982, talking about the condition for the first time by Dr. Hein Wellens. And in 2002, Reinhardt et al. Came up with these diagnostic criteria to describe Wellens. So your Wellens syndrome patient will have either deeply inverted or biphasic T waves in V2 and V3. Your Wellens syndrome patient will have an either isoelectric or minimally elevated ST segment in these leads. It will never cross the STEMI line. If it crosses the STEMI line, then you'll be talking about STEMI rather than Wellens syndrome. There will be no precordial Q waves in the ECG. Your ECG will show preserved R wave progression, so there will not be poor R wave progression, because this is a sign of ischemia. The MI hasn't happened yet. And lastly, the patient will present with a history of angina, but when you do the ECG changes will be in the pain-free state. So the patient will be coming with a history of chest pain, but will be pain-free when you do the ECG. And if you do troponin, the results will be either normal or slightly elevated. So these are the diagnostic criteria of Wellens syndrome. And as you can see here, my patient fulfilled all of them. So what you need to know about Wellens syndrome is, if you treat Wellens syndrome medically, 75% of patients will develop an anterior wall STEMI within few weeks. Mean time is 21.4 days. So this patient needs an angio, needs an intervention as soon as possible from the cardiology side. So we need to understand why the patient presents that way. You need to understand the pathogenesis of Wellens syndrome. So let me explain what happens here. Remember, the patient presented with a history of chest pain that was 12 hours before coming to us. You know what happened at that time? This was an acute occlusion of the LAD. This patient had the chest pain, and if I was there and I did an immediate ECG while the pain was happening, I would have seen a STEMI. This was a STEMI when the patient was there. But the ECG hasn't happened because there was no one around to get the ECG done, and reperfusion has happened somehow to the LAD. Whether this is because of the natural thrombolytic system of the body, or because the patient received some external aspirin, or whatever reason, reperfusion happened to the completely occluded LAD. So once reperfusion happens, pain will start to improve till it completely disappears. The ST segment will go down again, and the T wave will start changing its shape from being biphasic, moving to be deeply inverted symmetrical. This is actually, if you've done a cardiology job and you've been to the cath lab, you will see this happening when they take patients with STEMI to the cath lab. They reopen the vessel, and then they will see Wellens syndrome happening in front of their eyes. These are reperfusion changes that happen to the ECG. So this morphology, if you see in the cath lab, that is a happy surprise. That is a sign that the reperfusion was successful. The ST is going down, and the T wave is changing as expected with reperfusion. So now you've got a patient who's had the reperfusion. The artery, if remains open, the T wave will keep evolving from the biphasic shape to the deeply inverted shape. But the problem is you're now sitting on a very unstable coronary perfusion. This is simply an accident that is awaiting to happen. You're literally sitting on a time bomb. And the problem is you don't know when it's going to explode. And the only way to find out is just to pass it on to the cardiology team to have a look from inside and find out. Because if it happens, if the second occlusion happened, the chances are you're not that lucky, and your patient is not that lucky, and it's not going to reopen again spontaneously. So if it happens again, that will be an anterior wall STEMI. So this is the pathogenesis of Wellens syndrome. This is why what happened. So this is the progression of the STEMI when it happens. So normally, you'll have normal ST segment, then you'll have a STEMI. So if you look at the A type, so it starts with the ST elevation, then the reopening will happen, and you will see here, as you see here, the biphasic T wave, and then over the time, the ST segment will start going down. The T wave will change from being biphasic, more negative, till it is fully negative at type B. So this is the spectrum of changes that happens with any STEMI when reperfusion happens. If this happens in the cath lab, that will happen with a stent inside, so there will be no reocclusion. But if it happens before coming to the hospital, then what you will see is something along this spectrum in a patient who's pain-free. And that will be the issue in this case. If you miss it because the patient is pain-free with negative troponin, you'll be in trouble. So where we were not sure, if you don't know about Wellens, that referral will be an issue for you. The medical team will say, well, why do you want to admit this patient? If the patient is pain-free, negative troponin, serial ECGs, no dynamic changes, what do you want me to do? And they'll have a point. And when you speak to cardiology, they'll say the same. Why do you want to admit this patient under us? You can speak to the medical team. There is no acute intervention that is required now. You might get a suggestion. The problem here is no one has seen the ECG other than you. So everyone is just relying on your personal interpretation over the phone. So if you don't describe it well, if you don't mention the word Wellens, then there is a chance that you're not going to all be on the same page while having this discussion. And this is the dangerous part about Wellens syndrome. You need to mention the name. You need to know it so you can mention it. So let's imagine that you've never heard about Wellens syndrome and you're trying to speak to the medical team overnight. The medical registrar might say to you, well, I can see your concerns. You're worried about a patient who's got some chest pain hours ago, now pain-free, and there are some changes in the ECG that we're not sure if they're new or old. I can see your concern, but the problem is I have only a couple of hospital beds that are available now. So why don't we send this patient home, then bring the patient for stress testing in the morning and a chest pain clinic? This might sound reasonable if you don't know about Wellens, because it makes sense. So there is a chance that you might end up in this situation. And that's the danger here, because stress testing of Wellens syndrome is fatal. It can induce an MI and a VF cardiac arrest. So if you're suspecting Wellens syndrome, the treatment is urgent/emergent coronary angiography intervention. So stress testing, please get it out of the equation. There are two types of Wellens syndrome. So there is the deep symmetrical T-wave inversion type in the mid-precordial leads. That's the more common one because that's the end stage. So all patients will end up with the T-wave inversion at the end of the spectrum. And there is also the biphasic T-wave in the mid-precordial leads. It's less common, but it's a quarter of the patients. So you can see either or depending upon at which point you're going to do your ECG for your patient. So let's have a look at some examples here. This is our patient that we've talked about. And this patient, he was discussed with the cardiology team in Bournemouth, and the ward Wellens was mentioned, and the cardiology team advised an immediate transfer to Bournemouth Hospital. And let me be honest here with you. When I ring cardiology with a case of a Wellens syndrome, I would expect and accept different responses. So if they say to me, yeah, we're happy, send the patient now to the cath lab, yeah, that's fine, I am happy with this. They might also say, send the patient to CCU in Bournemouth Hospital. There is no cath lab availability now. We will see in CCU and we will take to the cath lab when we can. Again, I am absolutely happy with this decision. And they might say, admit the patient under the medical team in Poole Hospital as Wellens syndrome, and we will liaise with the medical team when we have the capacity in our CCU to transfer the patient. And if any changes while the patient is under the medical team, please get them to phone us immediately. And again, this is a very acceptable decision because Wellens syndrome is a condition that doesn't require, if it is just Wellens syndrome, doesn't require the cath lab intervention to be immediate. It needs to be happening within 24 hours. So I am happy with all of these. What I am not happy with is send the patient home. It is nothing. And you're not going to get this response if you've got a good story for Wellens and a good ECG and you've mentioned the word Wellens syndrome. Because again, remember, the cardiologist is listening to you over the phone, not seeing the ECG, and they didn't take the history themselves. So it's all on you to give the good history and the good interpretation of the ECG to come up with the correct plan. So for this particular patient, the patient was transferred to Bournemouth CCU pending cath lab activation later. Here is another example. And this patient was sent straight to the cath lab, and the patient was pain-free with this ECG, straight to the cath lab, and there was a completely occluded LAD there. Here's another example from Queen Alexandra Hospital in Portsmouth. And this patient actually presented pain-free with this ECG. The patient was admitted overnight, and in the next morning, he was sent to the cath lab and was found to have a critically stenotic proximal LAD. And again, this is type 2, the biphasic T-wave pattern. Here's another example. This was one of my patients from Poole Hospital again. And this particular one was quite interesting. So this is a type 2, as you can see in V1, V2, and V3. We've got a beautiful looking biphasic T-wave here and there. And the cardiologist said to me, send straight to the cath lab in Bournemouth Hospital because we've had the dynamic changes here. So let me show you the serial ECGs of this patient. This was his first ECG. So we've got a biphasic T-wave in V1, V2, V3. And it's mainly positive rather than negative, the T-wave. Then that's ECG number 2. The positivity is less, the negativity is more. ECG number 3, ECG number 4, ECG number 5. We've started with type 2, and we've ended up with a type 1 in V2. So that was a great example of the dynamic changes happening while the patient is completely pain-free, sitting, smiling, trying to reassure me because he felt that I'm super worried about him. So looking at this ECG, I'd like to ask you a question. Which type of Wellens syndrome do you think this ECG is showing? Is it type 1, the symmetrically inverted T wave, or type 2, or not Wellens? Have a look. Scan the QR codes, give me the answer. Let's see what you think. Okay, so the majority are going with not Wellens, and some of you are with 1, some of you are with 2. Okay, let's, I agree with not Wellens because there is something called pseudo-Wellens syndrome that we need to talk about. So if you look at this ECG, you will notice clearly that we've got a biphasic T wave in V3, V4, V5. But if you remember with Wellens, the T wave was positive and then negative, while in here, it is negative and then positive. So this is actually hypokalemia. This is an inverted T wave followed by a U wave. And that's why it looks biphasic, as you can see it here. So when you think Wellens, the T wave needs to be positive, up then down, positive then negative. While with hypokalemia, it's down and then up. It's negative then positive. So be careful about this because this can be very misleading. Here's another example. And this time it's clear that it is positive then negative. So we should be happy to say this is clear Wellens pattern of T wave. But be careful. Look at how high the voltage is here. This is a left ventricular hypertrophy. And the problem with left ventricular hypertrophy, this patient was known to have HOCM, by the way. Left ventricular hypertrophy on its own can cause T-wave changes that are very similar to Wellens syndrome. So I'm not saying that you cannot have Wellens in presence of left ventricular hypertrophy, But I'm just saying, be very careful before calling it Wellens, and please make sure that you've got a good story to support your ECG interpretation, because just T-wave, just left ventricular hypertrophy can get you the same presentation, the same ECG pattern of Wellens syndrome. So here's another example, and in this one, you might feel, looking at V2 and V3, that we've got an element of a tad bit of ST elevation with maybe a bit of a biphysicity trying to happen here. But actually, this is a benign early repolarization, or actually early repolarization because it was found not to be that benign anymore. So the presentation here will not be a Wellens presentation. You're not going to have the cardiac sounding chest pain, then pain-free period with this ECG. The usual presentation, the patient will usually be a young, it will be athlete, usually of Afro-Caribbean origin, and it's going to be almost always a boy with a high voltage ECG. There is also another nice sign in this ECG that I'd like to highlight here for you. So if you look at V4 and V5, we've got this lovely notch at the end of the complex here. So let's make it bigger. So this is something called the fishhook sign. So the fishhook sign is one of the patterns that points towards early repolarization rather than anything else. So it's not pathognomonic, but it's something to highlight here that could help you getting the diagnosis that you would want. So it is, looking at the chat, J-wave, it is very similar to the J-wave, but in the context of early repolarization, they call it the fishhook sign. So in summary, talking about Wellens syndrome, it describes a specific T-wave change in the mid-precordial leads. Usually, V2 to V5, changes can be anywhere from V1 to V6, but the usual is going to be V2 to V5, mainly V2, V3. It is specific for severe stenosis in the proximal LAD, so be careful about this. The dangerous thing about Wellens syndrome is that the patient will be pain-free, the troponin will be negative, you might not get dynamic change in the ECG, so it can be very misleading, and there is a good chance that you might end up sending this patient home or sending this patient for stress testing, and this can be fatal. Remember that there are two types of it, the biphasic type and the deeply inverted symmetrical T-wave type. And lastly, if you leave this patient untreated or you just treat medically, 75% of them will develop an anterior wall STEMI within the next 21 days. And there is no way to predict whether this is going to happen in 5 minutes time or in a 21 days time. So don't take any chances with those ones. Don't check your luck. And this is it regarding the Wellens syndrome. I thought I'll make it nice and sweet and short from my side so I can have all the time needed to answer your questions. And I really hope that you can all now see the STEMI coming from a distance before it bites you. Okay, so just to let you know, this talk was part of a course that I run. It's called the Emergency Physicians ECG course. The next one is in September, the 24th. This QR code will take you to the course page if you would like to have a look, be my guest. So that is just something that I wanted to share with you. And these are my contact information. So again, feel free to stay in contact. I'm planning to keep doing these webinars every couple of months if this is something that you're interested in. I like teaching, so I find this useful for me while I prepare, and I hope it's useful for the others. So yeah, stay in contact. If you've got any interesting case, please feel free to send them to me after removing the patient data. And yeah, I'll share them with the others and I'll use them for teaching with your name on. So feel free to share that with me. And yeah, thank you very much. My job is to try to make ECGs not scary, and I hope that it worked. So thank you so much, and looking forward to talk to all of you very soon. Bye for now.